So I looked at all your slides and I was coming together with everything that I thought would be important and adding things that I thought may or may not have been missing. So the first thing that I want to go over is like what this system actually does, whether you're doing this for med
Girl, you
surg
got
or
some heat.
patho. Um, None of it really changes, right? Because when you study for the NCLEX, it's not going to be med surg and patho. It's going to be cumulative, and everything coincides with everything. So I just want to put that out there. But yeah, so we have our musculoskeletal system, which means our muscles provide us with movement, and our bones are the structure, right? So that's what's helping us move and do the things that we need to do. But our bones help protect like our lungs and our heart and other vital organs. It helps us move. Our bones and our muscles play a very important role in producing heat and maintaining our body temperature. Helps with facilitating return of blood flow to the heart. And our bones are really important for producing blood cells, right? Such as RBCs, WBCs, platelets, right? Bone marrow is what creates those things. That's where they all come from. So, just quickly, we have 206 bones in the body. You don't necessarily need to know all the types of bones, but just know long bones are an example, would be a femur bone. And I want you to pay attention to that because I'm going to mention long bones again. And I just want you to have an idea of what kind of bone that would resemble. So for pathophysiology, right, or to understand all of these disorders for med-surg, you really have to understand what's going on, right? Or just about the diseases in general. So we have osteoblasts. Blasts are the ones that actually help in making the bone form. It's the bone formation. Osteocytes help with maintaining the bone, okay? So it takes the bone cells and it helps control those calcium and phosphorus levels that are essential for bone maintenance. Then we have osteoclasts, another type of cell in the bone that's primary purpose is to break down bone. And you're going to see that most of the pharmacological drugs that we use to treat musculoskeletal disorders actually inhibit osteoclasts because a lot of the problems that we'll see, the problem is due to osteoclast breaking down the bone. So that's why these terms are really important to be able to understand what each of them mean. So,
Question, you
oh,
you said that the blast was what? Like the blast by itself?
so the blasts form bone.
Okay, cool. Thanks.
You're welcome. Yeah, so the blasts form the bone, but the osteocytes are the ones that control maintenance of the bone, those calcium and phosphorus that make our bone structure stable. It controls that. But the osteoclasts break down the bone. So blasts are for bone formation, but the clasts, the ones with the C, break down bone. Okay. So osteogenesis is just the process of bone formation. All of those things that we're talking about with the osteoblast, that's just what it's talking about. And really, really important parts is calcium, right? And vitamin D. Vitamin D enhances the absorption of calcium. So the more vitamin D we have, the better we're able to use calcium, which is really good for our bones. Moving around and weight bearing exercises like walking, jogging, going to the gym helps with strengthening our bones. The parathyroid hormone is really important. Why? Because it controls calcium. If we have hypothyroidism, we have low calcium levels, which affects our bones. Similarly, if we have hyperparathyroidism, we have too much calcium, and that's a problem too. Calcitonin is a hormone that we find in the thyroid gland, actually, and calcitonin is just used to help control calcium levels to actually lower them. Okay, that's going to be really important when we talk about our medications. But as I said, think about vitamin D and calcium when we're talking about bones. Now, with the pathophysiology, I've never personally been tested on the bone healing stages, but I would just review it, right? So, like how the bone forms is essential to some of the pathophysiology that we're going to talk about, but not in terms of med-surg content. But just a quick review, we have stage one, which is where we have a hematoma, right? We have some sort of like blood forming, right? If when a bone fractures, we get a hematoma, we get bruising. Then we get fibroblasts, okay, and osteoblasts start. So fibroblasts help build up that tissue and help bringing up with getting the bone more together. And the osteoblasts, remember, are responsible for forming the bone. Then we get a callus, which basically helps make the bone much harder during the third or fourth week. And then finally, the bone is good, and we get to stage four, which is remodeling, where those osteoclasts comes in and removes anything that's not supposed to be there. So necrotic bones or bones that died, or maybe something happened, the osteoclasts kind of come in to make sure the bone is good. So besides the bones, we have joints, right? So joints help us move, okay? So different types of joints, just for reference, we have synarthrosis, which are immovable joints. We have ampiarthrosis, or allow limited movement. And we have diarthrosis, or freely movable joints. Those are the ones mainly that we talk about or focus on. And those include like the ball and socket, the hinge, saddle, pivot, and gliding. Like I said, I don't remember exactly where everything is. I believe the ball and socket is within the shoulder. So just definitely knowing where those locations are for the joints would be good for patho as well. But regardless, joints are important for movement, right? Especially the ones that we're talking about, those diarthrosis ones. All of those different ones play a really important role in movement. And when we're talking about the joint, right, we're talking about one, a joint capsule, right? So that surrounds the knee, and it basically has fluid and all of these things around it to help it move, okay? Then we have ligaments, which basically means we're connecting bone to bone. Tendons connect muscle to bone. And the bursar sac is like a fluid-filled sac that's predominantly in the knees, and they basically work as a cushion to help glide and reduce friction. So we need this sac in our joints in order to help reduce friction, right? Because if the bones start rubbing, they're gonna start undergoing breakdown, and that's gonna be really painful. So we need a way to reduce the friction or that tension in between the bones. So these are like important structures of the joints. Just as an example, in the knee, I'm sorry, this is a little blurry, but we have, like I said, a joint cavity or a synovial joint where we have that fluid, and all of that fluid is going to help with the friction. And then we have different cartilages and all of this stuff that interacts with helping us move. Now we have muscles, right? We know that muscles are attached to bones and we need them for movement. We have involuntary and voluntary muscles, right? Voluntary meaning the ones that we can move, like our arms and our legs. Those are the ones that we can control. But we have involuntary muscles like, our heart and lung muscles that work automatically. The main thing I want you to get or know with the muscles is that we have something called a sarcomere, which is the contractile unit of the skeletal muscle, which means these actin and myosin keep going hand in hand together and keep moving so that we can move. Okay, that's what actin and myosin play. The role is to help the skeletal muscle or our voluntary muscles move. Okay, so we need to maintain our muscles, right? And if we don't, things can happen. If there's a problem with muscle tone, we have, they could be flaccid, very, very weak, spastic, they move a lot. And if you remember from my pharmacology, baclofen is a medication that works in the central nervous system that helps with spasticity or too much movement in the muscles. And we have atonic or no movement. Okay, so those are issues that could happen with muscle tone. Oh, sorry. We can also have problems with muscles if we use them too much or not use them at all. So here's what are some things that can happen in our muscle cells. Normal, same size, nothing changes. We can have hypertrophy, increased cell size. So it just gets bigger. The size, not the quantity, not how many, but the actual size expands, right? This would be an example of, like, let's just say ventricular hypertrophy, right? When the heart works too hard, that muscle works too hard to pump blood to the rest of the body. And as a result, the muscle gets bigger and thicker because it has to work harder. We have metaplasia, or conversion of one cell type to another. You typically could see this in your GI tract, right? When we need certain sorts of changes, and even potential cancerous cells will change one cell type to another, right? Because we need certain types of cells in our body to work certain things, and if they change, that can change the function of that area. Atrophy means the cells get smaller. So hypertrophy means they get bigger. Atrophy means they decrease. This is when you don't use it. Meaning if let's just say you have a very sedentary lifestyle, you don't move, you're at risk for your cells to be undergo atrophy, and that's not good, okay? Another thing that we have is hyperplasia, which means increase in cell number. So we have, for some sort of reason, our body is increasing the amount of cells. And dysplasia means that we have cells of a bunch of different sizes and different borders. There's no sort of irregularity. Everything is just not normal. This would definitely be seen in cancer, right? When we have different cell types, that would be letting us know there's something wrong with our patient because this should not happen. Now that we talked about what can happen with the cells, that's just important things to keep in mind, right? But what do we do, or how do we assess the musculoskeletal system, right? Well, one of the most important things is how can they function in their day-to-day lives, right? So ADLs are their activities of daily living, right? Can they move? Can they do things safely, right? If they have a musculoskeletal disorder, or even if they don't, how do they get around? Do they have a family history of any sort of musculoskeletal problems? Any sorts of medications, right? How are they taking care of themselves? As I said, if they don't exercise or they have a sedentary lifestyle, that's going to affect their muscles. So, the priority assessment when we have a musculoskeletal issue is neurovascular. And we call these the 5Ps. So, we look for pain. Are they having pain? Are they having pallor, or the areas becoming pale? Do they have pulses? Do they have parasynesthesia, or numbness and tingling? And do they have paralysis? Are they not able to move? Okay, this is the priority assessment in all of the disorders. So the number one thing you're going to write down is when I'm looking at a question that relates to musculoskeletal function, or what should the nurse do first, they should look at the neurovascular status of the patient. Okay, those are the things that we're looking at, those 5Ps. So we also talked about bones, and one of the most important skeletal processes is our spine, right? Our spine helps us pretty much coordinate everything with our movement and with the nerves that play a very important part in the muscular system as well, with that sacromere, right? So just a few different types. We have kyphosis, which is basically a forward rounding of the upper back. It's very normal or very common in older adults. We have lordosis, or we have an inward curve of the spine. So it's hard to tell, but that lumbar area of the spine or that lower back is affected. Then we have scoliosis, which is a sideways curve of the spine. It looks like an S, which is figure C. So they're going to be a little slanted, okay? And usually one shoulder is higher than the other. So that's an indicator to let us know, hey, they might have scoliosis. Now, one of the most commonly tested NCLEX things or topics is rheumatoid arthritis. Now, rheumatoid arthritis is a autoimmune problem, okay? It's not like regular arthritis. This is specific to the body working against itself, okay? So it's an autoimmune disease, and typically something that we see is called a pannus. So it forms at that synovial tissue where we have that fluid and that helps with the friction, as well as that cartilage, all of that working in those spaces. And it can eventually cause necrosis. So it kind of like blocks the ability of these tissues to work, and it could lead to necrosis or death of the tissue. Rheumatoid arthritis is typically displayed with flare-ups. So it's not just, oh, okay, it's every single day. It comes and goes. They have periods of symptoms and periods of no symptoms. The symptoms are, right, if we're talking about arthritis, anything that ends in itis means inflammation. So if they have rheumatoid arthritis, they're having inflammation, tenderness, stiffness of the joints, okay? Because the joints are having a problem. The our body or autoimmune going against ourselves is going against the actions of the joints, making them stiff and tender. So there's decreased movement. And something that's really characteristic of rheumatoid arthritis is that they are going to have pain worse in the mornings, lasting longer than 30 minutes. That's because imagine when sleeping overnight, right? Maybe you're laying on your hands or you're not moving much, and then you wake up and you have to start getting things together. You haven't moved your hands for 8 hours. It's going to be very painful to get your hands to do what they need to do when it's already stiff and inflamed. Something else that you're going to see is that when you palpate the hands or wherever the rheumatoid arthritis is manifesting, it's going to be spongy and it's going to feel soft. And lab values that we'll see is elevated ESR or erythrocyte sediment rate, which is going to increase when they have rheumatoid arthritis, as well as a positive rheumatoid factor. If we see those in their lab values, if those are elevated, or if the rheumatoid factor is positive, they have rheumatoid arthritis. Now, there's a bunch of different diagnostic tests, not for this, but just generally when we're talking about musculoskeletal disorders. So, this is actually really important, and I was tested on some of these, but the ones that I was mainly tested on was MRIs, as they are the most commonly seen, as well as biopsy. But diagnostic tests these are used for studying the bones, looking at the structure, seeing if there's something wrong with the musculoskeletal system. So, we have an MRI. MRI, we can hear a knocking sound, okay, during this test. The thing is that there's very important contraindications that the professors usually like to test on is that one, they're going to be in a confined space, so this is not good for patients who have claustrophobia. They cannot have metal in the room. No credit cards, no hearing aids, no jewelry, no hair clips, because the MRI machine is magnetic and everything's gonna pull towards it. It's very, very strong. So none of that. It could also even cause burns if that metal or metallic jewelry or hearing aids lie on their system while they're undergoing or in the MRI. It can cause burns. Also, like nitroglycerin or lidocaine patches, anything that they have a patch for, they have to be removed because that can also cause burns. We must also assess for allergies because they will get contrast testing, and that contrast testing contains iodine. So if they have a sensitivity to iodine or shellfish, that could be a problem. I see a hand raised for a question.
Yes, it's me. I have a question with, you know how you said that MRI works with not magnetic? So my question is for a patient who went through surgery, like let's say years and has a knee repair, right? The knee they put like a metal in there. What other diagnostic tests do they do besides that MRI since it's a magnetic that can, tear the skin and like you explained earlier.
That's a really good question. I've never seen like my professors mention anything about it. Like you said, if they have maybe let's just say an internal pacemaker or like a metal joint or like a rod in the leg. I would probably say maybe they would go for a CAT scan or a bone scan. Um, maybe through it, I guess it depends on what it is. If it's necessary, they might have methods to do it, but that's a really good question. I actually don't know. I'll try to search it, but I'm not too sure. I guess maybe they would go through, like I said, a CAT scan or a bone scan, um, or something else to determine if there's like some sort of problem that they can't see. That's a really good question, though. I'm not really too sure. Um, but yeah, I will definitely search into that and let you know. It might say it's safe because it's internally, as compared to it being externally. So I'll try to search into that. Um, but yeah, so no metal, and we have to watch out for iodine allergies. Okay, so in arthrography is we're kind of looking at those joints. So they may feel tingling or discomfort, okay, for 24 to 48 hours after. That's what we're going to tell the patient. They can go for a bone scan if needed. And if they go through a bone scan, we're also going to assess for allergies, but for radioisotopes. And that's because they send the radioisotope through their IV in order to look at the bones better. So if they have an allergy, that's not going to be good. And we want them to have lots and lots of fluids because that's going to help distribute the isotopes. Um, Arthroscopy is more or less looking at also joints, but after the procedure, we're going to wrap the joint with a compression dressing so that we can help reduce swelling. And as I said, neurovascular status or neurovascular assessment is the priority. And always, right, instruct family members about signs, symptoms, and complications. And for this procedure, avoid strenuous activities. For arthrocentesis, it's kind of similar to a thoracentesis or a pleurocentesis. Anything that ends in synthesis means that we're removing fluid. So in this case, we're going to remove fluid from the synovial joints, which is causing that inflammation and pain. So we're going to remove hair from the procedure site so that nothing can get in. Administer pain medications, to help ease the pain. And after the procedure, we're going to apply ice for 24 to 48 hours post-procedure because we want to reduce inflammation and swelling. Electromyography. Now, myo means muscle, right? So we're looking at the electrical conduction of the muscles, and we use it to evaluate muscle weakness, pain, and disability. We also have to be very careful for use of anticoagulants. Why? Because the electrodes that are used during the myography can cause bleeding, and anticoagulants increase the risk of bleeding. So we don't want them to bleed out. And that's a rule of thumb for any surgery. If a patient's taking an anticoagulant or a blood thinner, they should always, check with their doctor to see how long before they should hold their medication when bleeding's at risk because they could potentially bleed out, okay? And also watch for skin infections. If it's going to be a little invasive, like these might cause bleeding, we have to be careful and watch out for signs of infection. Lastly is a biopsy, right? This is where we're getting a sample of something, right? So if we're doing a biopsy, we must monitor the site for bleeding. That is the priority. The priority is watching for signs and symptoms of bleeding, right? So if they have bruising at the site, right? Or frank red blood on the pad a couple hours after, they're bleeding. And we really need to then do, make sure we put pressure to the site and notify the doctor so that we can have the appropriate interventions. Okay, so those are different diagnostic procedures, to look at different things with musculoskeletal disorders. I've personally been tested on MRIs, biopsies, and electromyography. So I'm just pointing out those might be more of your focus if you need to narrow down what you want to study. But okay. So, a common thing that we want to talk about is how do we assess a patient with low back pain, right? So, this is all going back to fundamentals, right? We want to do our old cart, or we want to look at onset, location, duration, characteristics, associated manifestations, all of those things to know where is the pain coming from. Has the patient tried anything to relieve it? What causes the pain? Is it work? Is it during an activity, right? Is it the lower back pain from something like lordosis or scoliosis, okay? So we want to look at that. And we also want to assess, like I said, how it affects their mobility, right? How it affects their activities of daily living. Remember, that's very important to the assessment of the musculoskeletal system in general. And neurovascular status is the priority. So we're looking at sensations and muscle strength and whatnot. We also want to look at their posture, position changes, and gait, or their ability to move. That's going to let us know a lot about what's going on with the patient. Now, interventions, right? If they have pain, we want to treat the pain, right? Exercising can help with pain, depending on what the reason for the pain is, right? Maybe modifications at work, activities to promote a healthy back, and maybe even dietary and weight reduction, right? Because weight can hurt your back. And something that can also hurt your back is lifting. This could definitely be on your exam as a picture of somebody lifting something. and asking if this is the proper technique, right? So you should always go down and pick up something. You should not hunch over with your back to lift something. That's not good. You should also always stand upright, right? Because if you don't stand upright and you kind of hunch over all the time, you do have the risk of getting like kyphosis or like a little bit of a hunchback. So we have another really, really important musculoskeletal related disorder, and it is carpal tunnel. Now, carpal tunnel is when we compress a medial nerve, and it runs right in the center of your wrist. And there's actually a few different tests that you can do. We'll get into that, but actually, to see if someone has carpal tunnel, something that they do is they ask you to do prayer hands and hold it there for 60 seconds. If it's painful while doing that, they might have carpal tunnel. And if you do the inverse, where you kind of hold it, your hands, the back of your hands side by side, and your fingers are pointing towards the bottom, and they also hold that for 60 seconds. If they have pain, that's also a sign of carpal tunnel. But it's a compression of the medial nerve. And the medial nerve consists of most of your fingers except the pinky and the ring finger, right? It's some of the ring finger, but it's mainly in the middle, the index, and thumb. Okay, so risk, really important, right? Who is at risk for carpal tunnel? One, women who go through menopause because of all the hormonal changes that they're having in their body. People who are taking estrogen or birth control pills also have a risk because of the balance of the hormones. Who else? People who are employed that do repetitive typing motions and all of that and use their wrists a lot, like hairdressers, secretaries, things like that, construction workers, they're at high risk for carpal tunnel, and it's very painful. What are signs? Pain, numbness, tingling of the hand, especially at night, because I had a pinched nerve and I damaged my wrist a long time ago during volleyball. And long story short, when you sleep at night, you're not really moving it as much, and that increases the pain of the nerves. So they're also more active at night. Um, so that's just another thing that it increases the nerve pain. So they could have tingling, especially at night, which makes it very uncomfortable. Um, and like I said, repetitive movements of the hands and wrists are ways that you can obtain carpal tunnel. And this is just an example of the ligament and the nerve. So the ligament is pressing on that nerve, which is causing the carpal tunnel and the discomfort. So if you also tap the area in which that medial nerve should run, that if that causes pain, they also have carpal tunnel. Now, I was talking about diagnosis or compression tests. So we have the Tinel test, which is you press on the nerve to look for numbness. And you do the balance sign, which is where you're doing the flexion of the wrist, either the prayer hands or where you're putting the hands back to back and your fingers are facing down. If they do that for 60 seconds and it hurts, that lets you know, hey, they might have carpal tunnel. Now, what is some really important teaching points or treatment that I should do? They should rest. They should put their arm in a splint. Immobilizing it is going to help reduce the pain, okay? A splint doesn't necessarily immobilize the same way as a cast, but because they're putting it in something that they're going to wear for the majority of the day, neurovascular, right? We're looking at, are they having pain, pallor, pulselessness, right? Are they still getting adequate perfusion in their hands? Steroid injection, because it could help with the inflammation, and if it gets really bad, they could have a surgery. Nursing management. If they go through a surgery, what is my priority? I just cut a patient's arm open. I should probably look for their blood flow and checking that neurovascular assessment of pain, pulse, parasynesthesia, um, paralysis, and all of that, okay, and their pulses. That's what we're looking for. Sensation in their fingers, right? Their wrists should always be immobilized in the splint. This is post-surgery when they're home and they're taking care of it. Always elevated on pillows, so it should be upright to prevent any sort of edema. And when they have this surgery, they should avoid heavy gripping and pinching for up to 6 weeks. Okay, that's what we want to tell our patient. Now we also have something called, I'm very bad at saying these things, but Dupuytren contracture. I'm probably butchering this really bad. But Basically, what this means is those tissues start to get really, really thick, and the fingers start to bend inwards, and they can't fully strengthen. They can't fully open up, okay? So the fingers get really stiff and they kind of stay there. That's what happens when someone has this. And you usually see this as a risk factor for someone who has diabetes. Okay, so now as mentioned before, we talked about certain patient teaching that's pertinent to carpal tunnel. But generally, if we're going to have a surgery to treat any of these conditions that affect the wrist, what am I thinking about? Neurovascular assessment and prevention of infection, as well as managing pain. And then eventually, how are they doing with their functional status? How are they able to perform their activities of daily living? Because we want to promote independence. Now, we already talked about neurovascular assessment, especially the first 24 hours. It's usually like every 2 hours on the clock, then eventually every 4. It's very serious, okay? Now, infection, right? Anytime someone has a surgery, we're always at risk for infection. What I want you to know is that infection might not show right away, right? They might not have purulent, like smelling drainage or really a lot of redness. And it's going to be hard to tell because they just had a surgery. So you expect the site to be a little red and a little inflamed, right? So if they have a fever or redness and warmth 72 hours or 3 days after a surgical procedure, they have an infection. They have an infection and they need to go back to the hospital and they need to get treated, okay? That's how we know. That's a rule of thumb. If 72 hours pass and they have a fever, they got to go back. Now, I've never personally been tested on foot problems, but if I were you, I would just take some time to review different sorts of foot problems, right? Like the hallux valgus is like a deformity of the great toe. This one, like I said, I'm probably not saying it right. We also have claw toe, right, which is also like an arching of the toe. These are just some pictures of common deformities. So hammer toe, the great toe, or like a bunion, the hallux valgus, it like kind of moves the toes laterally, and the hammer toe or the claw foot, they both sort of arch that the great toe. And yeah, so I would read through these. Personally, I've never been tested on them, but I would just look at it. Um, but if they have one of those deformities, right? The idea is it doesn't matter what they have. It doesn't matter what it is. MedSurg or the NCLEX is not going to specifically ask you, oh, what does the patient have most of the time, especially when it comes to foot problems like these. It's going to be my patient went to a surgery for an XY foot problem. What do I do as a nurse? What's my priority? Well, we already said if it's musculoskeletal, priority is neurovascular. Those 5 P's: pain, pulses, pallor, parasynesthesia, paralysis. That's what we're looking for. We're also looking at infection. We need to make sure that prior to the surgery, consent is on file. We don't get consent, the physician does. We don't do that. We witness that consent has been, that we saw them talk about the procedure and the patient sign it. We witness the patient's signature, but we do not obtain consent. That is the physician's job, okay? All of the things that we talked about here, looking at their mobility, things of that, it's the same things for hand and wrist. Surgeries generally are the same, right? We're undergoing a very invasive procedure, so we need to look at that neurovascular status and we need to prevent infections, and then we need to check their mobility, especially when it comes to musculoskeletal. So just repeating everything I said: priority, neurovascular assessment. We can relieve pain by elevating the foot using some ice packs, right? I mentioned already neurovascular status is usually every 1 to 2 hours. Mobility, right? We want to prevent a DVT, right? The more they're immobile after a surgery, the more they're at risk for clotting. So as soon as they can start moving, we want to get them moving. Okay, and if they need any assistive devices, we have to ensure their safety, right? So if they're unsteady, we can't let them walk alone. Measures to prevent infection: as I said, we need to keep the dressings clean. Always, doesn't matter the surgical procedure. Anytime there's a surgery, the first dressing change is always changed by the surgeon. Always, not us, the surgeon, because he needs, or she, or they need to check the site, okay? So we don't do anything for the first dressing change. After that, and they provide us instructions, we will keep the dressing clean and dry, follow their wound care procedures. And remember, 72 hours, if they spike a fever or signs of infection, we have a problem. Now we have osteoarthritis. Now, do not get this confused with rheumatoid arthritis. Okay, rheumatoid arthritis is autoimmune. Osteoarthritis is not really inflammatory. It's not systemic like rheumatoid. We have inflammation, tenderness. It's not like that. It's a form of the joint, right? Some joints are affected, but it's mainly caused by advancing age, okay? There's really no inflammation and things like that. Essentially, what happens is we get these osteophytes or these bone spurs, which I'll get into in a little bit, which are like these little I don't know how the word is like a little bulging coming out of the joint area. Okay, that's a sign that they have osteoporosis. Not osteoporosis, sorry, osteoarthritis. The joint space is also narrowed, and the joints can also progressively degenerate. Now, risk factors include, remember, old age. It's caused by advanced age. So that's a problem that we have, right? We also want to look at someone who has a history of a lot of injuries and muscle weakness, or even a genetic predisposition would put them more at risk, especially if they have an occupation where they had very strenuous work, they could have osteoarthritis, okay? And obesity is one of the most predominant risk factors for osteoarthritis. You could think osteoarthritis, obesity, and diet and exercise changes to help with if they are obese. Now, they have pain, they have stiffness, but they don't have inflammation, okay? They have joint pain that's aggravated by movement, but it's relieved by rest. They have some morning stiffness, but it's more or less in the evening, and it's less than 30 minutes compared to rheumatoid arthritis, which is more than 30 minutes. The onset is usually really, really slow. It takes a long time for this to form. And it's most often in those weight-bearing joints. So remember, we said a problem or a risk factor can be a laborious job. So we're looking at hips, knees, cervical, lumbar, things like that. Things that can be moving a lot are sites of where osteoarthritis can occur. Now, I think this is great. This little chart thing. So for signs and symptoms, you could think of osteo. So outgrowths or Herben's node, which is those bone spurs that I was telling you about, or those osteophytes. They can have them close to the nail, right? So right next to the fingernail, or they can have Bouchard's node, which is in the middle finger joint. Okay, so the O is for outgrowths, S is for stiffness, right? In the morning, but lasting less than 30 minutes. T for tenderness, right? So they're going to have hard and bony tender joints compared to rheumatoid, which is spongy. At E is where it's exacerbated by exercise. So, and it goes away with rest, which is unique to osteoarthritis. And remember, it's only in the joints. It's not systemic like rheumatoid arthritis. Management, right? Decrease pain and stiffness. We don't need anti-inflammatories because it's not an inflammatory process. Exercise, especially if they're overweight, to help reduce the strain on the joints. And maybe some pharmacological management if it's that bad. This is a really cute summary of the differences between rheumatoid and osteoarthritis. So you could take a picture of that, or like I said, if you want the slides after, just let me know. And yeah, but I think this is a great summary, especially because when you hear arthritis, it can get a little confusing. Okay, so the next thing we have is osteoporosis. Now, osteoporosis, what happens is that the bone becomes really porous, brittle, and fragile, right? This is because the bone is undergoing a lot of those bone reabsorption, or osteoclasts that break down the bone are being released more than the osteoblasts are, or the ones that form the bone. So bone is breaking down, okay, more than the rate at which it's being fixed. That is a problem. That means they're at risk for fractures, okay? What are risk factors for osteoporosis? Early menopause, because of all of those hormone imbalances, smoking, a family history, female gender, excessive use of alcohol, sedentary lifestyle, because if you're not moving, neither of those bones, and they're going to get weak, thin and small frame, and increased age. Remember, as you age, your bones are going to get naturally more fragile. And because the bone is breaking down, it's also going to make you shorter, right? Because imagine if these cells are breaking down the bone's going to get shorter and shorter. So you have some reductions in height, okay? So, how do we prevent this? I said before, what's so important for bones is calcium and vitamin D. They must have a high diet in calcium and vitamin D. That is the most important teaching point for patho, for med surg, for everything. Okay. Um, what else? They should do weight-bearing exercises, not heavy lifting, not weightlifting. We're talking about walking and jogging, okay? To 20 to 30 minutes every day to help with the bones. Nothing too crazy though, because they're at risk for fractures, okay? And we also want to tell the patient, hey, if they're smoking or they have a history of using alcohol, they should stop that because it's going to make their osteoporosis worse. Now, pharmacological therapy, calcium and vitamin D. Bisphosphonates, or they usually end in dronate. Well, aldronate is a biphosphonate. What this does is it decreases bone resorption by osteoclast. It basically decreases the bone breaking down. But a really, really important side effect of this class of drugs is esophagitis, which means inflammation. Remember, anything that ends in itis means inflammation. So inflammation of the esophagus, which means, right, respiratory potentially. So we want them to take this with a full glass of water so that, they can drink it and it can remove some of the medication from the throat to help, hopefully not to have any sort of swelling. They should sit upright, but if they have difficulty or pain and they feel like it's hard to breathe, they really need to go to the doctor and stop the medication. Calcitonin inhibits the activity of osteoclasts, okay? So it prevents bone breakdown and it keeps calcium in the bone, which helps with bone formation. Other things can be estrogen, agonist, antagonist, parathyroid, but these four are the main ones, okay? And I would pay very, very close attention to that. You're definitely, if they say something about osteoporosis, you already know calcium and vitamin D. That's, if it's a select all, you better click that one. You're definitely going to get a point for that one. But yeah, we already talked about the risk factors. So the risk factors are going to go into the assessment, right? Let's just say they get a fracture, right? Related to osteoporosis. We should look at their family history. Do they have a history of previous factors? How is their calcium intake, their exercise patterns, right? We want to look at everything to see how the osteoporosis and their history is causing these fractures. Is it something that we can do or help them stop doing to prevent these fractures, right? Looking at if there's pain, right? If they're having shortened stature, because that's something that can happen with osteoporosis. Goals, right? Think about it. We want to make sure they understand how osteoporosis works, right? You need to explain it to them. You don't need to get into the fancy terms, but you need to tell them your bone is weak. It's breaking down. And you need to increase calcium and vitamin D to help with preventing that. Okay, so we want to tell them and we want to make sure that they understand why they're doing the things they're doing. Okay, making sure that we can eliminate future fractures and relief of pain. Now, once again, everything just pretty much repeats, right? Preventing injury, improving bowel elimination, relieving pain, and understanding how osteoporosis works is important in terms of nursing interventions. Now, remember, osteo means bone. So if you don't even know, if you can't remember anything, at least you know this has to do something with bone. So you might be thinking neurovascular, you might be thinking, right, because that's the priority assessment, thinking about calcium, vitamin D, all of those things. So osteomalacia is basically inadequate bone mineralization. So there's a problem with that calcium and phosphorus that really help make up the bone. Remember, calcium and phosphorus have an inverse relationship. So if one goes down, the other one goes up, which doesn't help, okay? Or vice versa. This causes softening and weakening of the long bones. Remember I said long bones would be important? We're talking about bones like our femur. It's going to cause pain and tenderness and deformities of the bone. What do? Well, it's usually caused by a deficiency of vitamin D. We need vitamin D to increase the absorption of calcium. So we need increased vitamin D, increased calcium. For most of these bone problems, that's what's going to come up, okay? And they can be caused by different things, gastrointestinal disorders, renal insufficiency, because all of these things play a role with absorption of calcium, right? If you have a problem with your GI tract, you might not be able to absorb calcium. If you have renal insufficiency, you might not be able to excrete calcium. If you have hyperparathyroidism, you might have too much calcium. And a dietary deficiency, right? Are they not intaking enough calcium? Management, correct whatever's going on. If they have kidney disease, we could supplement with calcitriol. So if they have low levels and that's what's causing the osteomalacia, let's increase calcium, right? Malabsorption, we need, if they have some sort of GI problem, we want to increase vitamin D and calcium. Sunlight is a natural vitamin D stimulant. Your body can naturally produce vitamin D. So tell them, spend some 15 minutes outside, get some sun. You're going to be doing a lot more for them if you tell them go outside a little bit more, because they'll also get natural forms of vitamin D to help with their bones. Now, I don't know if this is called Paget's or Paget's disease. I don't know. But basically, the problem with this is that we have excessive bone resorption. We typically see this in a population of older than 50 and mainly in men. And it usually has a family history. So what happens is those osteoclasts are breaking down the bone. And we do have increased osteoblastic activity. Remember, there's an imbalance. So there's more osteoclasts and not enough osteoblasts. But the osteoblasts are trying to make up for it in this disease. So what happens is that the bones are breaking down and the osteoblasts are trying to compensate and increase. But in return, we're getting really weird bone structures. So the bones are going to grow larger and become weaker. So that's the problem. It's like the body's trying to compensate, but it's not really working. You typically see this in the pelvic or the pelvis and the skull area, but we don't really know why they get it. Regardless, it's a bone deformity, right? So something's going on with the bones. So we need to look at if they're having pain, tenderness, neurovascular assessments, right? And things that we can do, right? NSAIDs to reduce any sort of inflammation. Calcium, increase calcium. Biphosphonates to help slow down that osteoclast activity. I hope you're all seeing a pattern, because there definitely is a pattern here. Now we have osteomyelitis, which is myelitis, right? Muscle, or osteo, bone. So we have itis, inflammation of the bone, but this is actually an infection of the bone, osteomyelitis. This usually caused due to a staph infection. So just know, infection of the bone, it's usually caused by Staph aureus, which is a type of bacteria, which means we give them antibiotics. That's what we want to do. Remember, right? If this is infection, signs and symptoms of infection, localized pain, edema, arrhythmia, look for drainage, look for fevers, right? If it's chronic, the fever may be low grade naturally in the afternoons or evenings, right? There might be complications of antibiotic therapy, so we have to really watch out for that, right? And remember, if they need to take antibiotics a lot, they may become resistant, and that can cause other problems. So we need to really, really be careful. The goal is, right, all of these, relieve pain, help with mobility, right? Eradicate infection, and make sure they understand why they're getting this prescribed treatment. So I'm not going to repeat everything, but you get the drill, okay? Now we can get another type of arthritis, right? Remember, arthritis means joints, inflammation of the joints. We can get septic or an infectious arthritis. So they're getting inflammation of the joints because of an infection. High risk, patients over the age of 80 who have comorbid conditions. Diabetes increases the risk for infection. Rheumatoid arthritis is an autoimmune disease. Your body's going against itself, increased risk for infections. Or if they have a skin infection, remember, your skin is your barrier against other infections. So what are signs of infection? Warmth, pain, swollen joints, decreased range of motion, fever, chills. You get the drill, right? And even leukocytosis, meaning increased white blood cells, right? So we need to figure out what's going on, what's causing it, treat it, right? Antibiotics, pain relief, immobilization, right? And remove any fluid, right? Because sometimes the inflammation might build up so much from the infection that now we have like lots of fluid in that synovial space. So we might have to remove it. Okay, now we have bone tumors. Now these are really slow growing and they don't have many symptoms, right? If they're benign. So I would just know, I would be able to look at these and just know what they are. So like osteochondroma, bone cysts, osteoid ostoma, or osteoclastomas, those are all examples of benign bone tumors. Okay, that's all I would know. I would just be able to recognize them. Same thing with primary. Primary means that these are malignant. They metastasize, meaning the cells, remember we said metastasize means spread. So metastasizing in the lungs. Very scary. Anything that ends in sarcoma is a cancer. So osteosarcoma, chondrosarcoma, liposarcoma, fibrosarcoma. If you see that, you know it's a primary bone tumor. That's what I would want you to know. Secondary metastasizes not in the, as commonly in the lungs, but mainly in the kidneys, prostate, breast, ovary, and thyroid, but sometimes the lungs. And these are more common, okay? You typically see these in the skull, spine, femur, humerus, but I would just know for secondary, right, the problem is that we can't really do anything. They metastasize, and the treatment is palliative to promote the best quality of life while they're still here. Medical management, right? Depending on what it is, if it's benign, don't worry about it. If it's primary, surgical, radiation, chemotherapy. If it's secondary, it's palliative interventions. It's not end of life, but to promote life while they have this until they pass. Nursing management, right? Cancer can cause delayed wound healing. So we want to make sure, right, to see if there's any wounds that aren't healing, and we can promote interventions to take care of that. Watching out for infections and hypercalcemia, because remember, this is a tumor of the bone, which means potentially calcium can increase. It can leave the bone and get into the blood. And we always need to educate a patient, regardless of what they have, on the diagnosis, the disease process, and treatment. The last thing, I don't care if you don't remember what this is. That is fine. I want you, though, to say if you see the word joint arthroplasty, you know, okay, this means that they're going to have a surgery. They're going to have a surgery of something. What is it? It's actually a surgery to remove an unhealthy joint. Remember, arthro means joint. So it's something to do with the joint. You're going to remove the joint. We usually use this for osteoarthritis or rheumatoid arthritis or maybe some sort of trauma and certain fractures. But regardless, if you hear arthroplasty, think surgery. I need to implement surgical interventions, right? Like neurovascular assessment, priority, things like that, okay? So risk, always bleeding. If it's for the hip, if we're doing the hip joints, right? They usually say hip arthroplasty. We have to look at the hip. We have to watch out for venous thromboembolism, right? Or DVT, because the more they're not moving, because it's a surgery, they'll probably be on bed rest for a little bit, especially because it's in the hip, they're at risk for a DVT, okay? So we need to be careful with that. Infections and pressure injuries from sitting. Major goals, right? Always relief of pain, get them back to a functional state, and things like that. We want to prevent dislocation of the hip. So this is really, really important. What we want to do, correct positioning of using a splint. It's usually like a pillow or something to help mitigate the pain. And basically imagine if you had a surgery in your hips, right? If you're looking at your hips, you would be very uncomfortable sitting at a 90-degree angle in your chair. So we want to keep them less than 90 degrees, okay? They can't move their hip too much, okay? We also need to try to turn and reposition them when we can to prevent pressure injuries. What else? We need to get them walking as soon as we can. So 1 day post-op, usually a doctor will prescribe walk Y so we can prevent DVT, usually with assistive devices. Remember, weight bearing, it's a prescription. They can't get up unless the doctor says they can. And we also need to assess for bleeding and fluid accumulation, right? It's a surgery. Okay, we need to look at the bleeding. Prevent infection, remember, right? First surgical dressing change, surgeon. But if their fever spikes 72 hours and they have signs of inflammation and edema 72 hours after said procedure, we got to call the doctor. Okay? Remember, hygiene is the most important way, like hand hygiene, to prevent infection. So we must do that. You're at risk for infection for up to 24 months. Okay? So anything after 72 hours that causes a fever, especially in patients who are undergoing a hip arthroplasty, got to be careful. And right, prevention of DVT. How can we do that? Making sure we get up, we can elevate their foot and give them, preventative anticoagulants and things like that to prevent, clot formation and things like that. Okay. Mm.